So myself and Kate, who's one of the sonographers, are going to present this, but really this is on behalf of the whole team, and they're all the people here and lots of people who I don't even have space to name have helped us out with that. So I'd like to thank everybody that has been helping with our pathway. So could I just have the next slide, please? So giant cell arteritis is a condition where the blood vessels become inflamed, and this can cause headache and lots of other symptoms, but if we don't treat it very quickly with steroids, then it can cause irreversible visual loss. So it is a medical emergency. So our current pathway is that we treat this as soon as it's suspected with high dose steroids. So we and then we ask doctors to refer to us urgently. And previously, what we used to do is to then assess them clinically and request a temporal artery biopsy to confirm the diagnosis. And then once that biopsy had been done, and once patients had come back to clinic to have that result reviewed, they would then either stop steroids if the biopsy was negative and it didn't look like giant cell arteritis, or the steroids would continue long term for this disease. So our problem is that actually, because it's a really serious diagnosis, probably about 3 or 4 in 5 patients with suspected giant cell arteritis actually turn out not to have the disease. So they end up getting steroid treatment unnecessarily while they're waiting for the results of the test. So our challenge was to reduce unnecessary steroid use by providing a faster and more accurate diagnosis. So next slide, please. So what we did in order to do this was to add in a new test called a temporal artery ultrasound early in the pathway. So this sounds straightforward, but it was not straightforward. And we started by using what sort of QI methods and Leeds improvement methods. We did some pathway mapping and value stream map to look at how the pathway is working initially, look at the bottlenecks, and our target really was to reduce the number of days from starting on the pathway, the starting of steroids, to when they get that consultant decision and when they stop their steroids if they don't have giant cell arteritis. We set our targets. So before we introduced our change, the average was 28 days from the initial referral to that consultant decision. And we were wanting to reduce that to a target of somewhere around 7. So in January 2019, we introduced temporal artery ultrasound, and with a more rapid consultant review with the result of that ultrasound. So not all patients would necessarily need to go on to have that biopsy and wait that time. At that time, the pathway was running via St James's Hospital, and we were seeing patients up on J97 with suspected giant cell arteritis. So for various reasons, and as the COVID pandemic struck, we decided we would bring them direct to Chapel Allerton Hospital, which is where the ultrasounds are being done at present, so that we didn't need to bring them via St James's via the acute site, particularly during the COVID outbreak. So we teamed up with PCAL to set up a pathway where GPs could refer in if they have ocular manifestations. They would go to ophthalmology first. If they didn't have ocular manifestations, then they could go straight to Chapel Allerton and see us there without having to go through the acute site. Next slide, please. So I'm now going to pass you over to Kate Smith, who's going to explain a little bit about the ultrasound that we do and how all that works.
Hi, hope you can all hear me okay. So as Sarah said, prior to starting the ultrasound in January 2019, I actually went to Southend University Hospital and spent 2 weeks consolidating my GCA ultrasound skills there, and that enabled me to bring them to Leeds so we could ensure that we had a robust service from the beginning. So what we actually do when we look at ultrasound is actually look at obviously the vessels and the vessels at the side of the head and under the arms. So this top image on the slide here shows the dark tube-like structure of the artery that we look at, and there is some software on the ultrasound scanner that allows us to see the blood flow, detect any movement, and that shows the blood flow within the vessel, and that's demonstrated here with the red tube-like structure. So we look at it in what we call the long view, so along the length of the vessel, but we also turn the ultrasound probe through 90 degrees and look at the vessel, what you might call end on, if you can imagine looking down a pen end, and we look at the vessel end on there, and the bottom set of images show this as well. We can see that blood flow filling that vessel nicely, and it goes right to the very edges of the vessel. Next slide, please. But in an abnormal ultrasound, so one that has a giant cell arteritis, we can see on the top image here, we can see that we've got the red blood flow there still, but we can see there's a very dark area surrounding that blood, and this is the inflammation of the vessel walls, and this is what we call a halo. And we can see that demonstrated again on the cross-section view on the bottom image, where we get like the donut appearance with the blood flow in the middle. Next slide, please. What we also can do is something called a compression sign, and this is where we very gently press the probe against the side of the patient's head, and that squashes the vessel down. In a normal vessel, as you can see on the images on the left, we can see the vessel, once you've put some pressure on it, actually completely disappears. We can't see any sign of that vessel once the pressure has been applied. The images on the right, we can see the donut shape to start off with again, but once the pressure's been applied, we can still see those dark walls visible, and this is what we call a compression positive sign, and this is what we look for in signs of giant cell arteritis. We do also look under the arms. I haven't put any images of that on here, looking at the axillary arteries. Well, again, we can measure the thickness of the vessel walls, and that detects another subset of patients who potentially have giant cell arteritis. Next slide, please. Back to you, Sarah.
Thank you very, very much, Kate. That was great. So this is what the results of what we've done. So on the x-axis is time, so each data point is data for one calendar month, and on the y-axis is the time between, or what our lead time, so it's the time between when that patient first came onto the pathway and when they had that consultant decision, that consultant review to decide whether steroids should be continued long term or stopped. So as you can see, before we started making our change, the average was somewhere around 28 days. And we were able to track this because Andrea Sweeting, one of the medical secretaries, had set up a spreadsheet tracker just to track the patients coming through so we didn't lose any of them. So we were able to look back and see how long it had taken over this time, and it was relatively steady. So when we introduced ultrasound scan, we didn't tell people to stop doing biopsies. We just left it up to their clinical judgment, and we said, this is a new test, you don't necessarily need to do anything different, we're just going to do this as an add-on. But nonetheless, actually the average time to decision started coming down over that year, and as we got more and more confident with what the ultrasound result was showing in comparison to the biopsy, so most patients who are at this stage having both tests, we started to be able to make that decision faster and faster on average as to whether they should continue steroids or whether they could just stop their steroids. However, there was a bit of coordination because they would be presenting up to the St James's site, but then the decision was being made by consultants at Chapel Allerton, which is where most of us work most of the time. And so then we introduced our PCAL pathway, which was more of a one-stop shop at Chapel Allerton from March 2020, and then the time decision came right down. It did drop very low during the first peak of the COVID outbreak because we weren't able to do any temporal artery biopsies at all at that time, so we just had to go on the ultrasound. But then as we have been getting a bit more back to normal service and the vascular surgeons have been able to do biopsies again, we've settled so at around where our original target was, actually at around sort of 7 to 10 days average for the average patient coming through for the lead time metric. The other lighter wiggly lines are the sort of the subcomponents of that lead time. So the orange is the time it takes from the referral to the biopsy, the grey is when the biopsy is done to when the biopsy report is available, and the light blue at the bottom is the number of days patients waited to have a temporal artery ultrasound. So you can see that we are able to do ultrasounds just within an average of 1 or 2 days for most patients, whereas the time for biopsy is about the same as it was. The reporting has got a little bit quicker, but because fewer patients are needing a temporal artery biopsy, we're able to bring that average wait time down. So next slide, please. So we also have been looking at clinical indicators, so not just the speed of pathway, but indicators of how well we're doing as clinicians on this clinical decision. So one thing we wanted to look at from the start was what percentage of patients we decide to treat actually have evidence and support of this. This is important for two reasons. One, because there's a known error rate, and the more patients we're treating who actually have a positive test, I think the more likely we are that we're making the correct diagnosis, we're not overcalling this disease. And then secondly, these tests are, a positive test is required for eligibility for biologic therapy later on down the line. So if a patient, if we're really convinced the patient has giant cell arteritis, then if we can get them a test which demonstrates that they have the disease, then that gives them more therapeutic options later on down the line. And although it's a very noisy graph, it's looking like actually over time, since we made our first change January 2019 and our second change with PCAL, we are gradually improving our rate of test positivity in the patients we decide to treat long time for giant cell arteritis. So the median percentage of patients with positive test before January 2019 was 29%. But since January 2019, 56% of patients who are treating long-term for GCA have that positive test, and that's been gradually rising since that time. So next slide, please. But our primary goal was to really reduce unnecessary steroid use. And again, this is kind of noisy data, so this is a rolling average. But before January 2019, the median prednisolone dose taken by patients who did not have giant cell arteritis and in whom it was ultimately stopped was 1.34 grams of prednisolone, which is an awful lot and definitely enough to cause significant side effects in a lot of patients. And that has been coming down since January 2019, and the median was 0.41 grams last time we looked at, and then since we've been able to do the one-stop shop via PCAL, we've had that confidence we can get that ultrasound quickly and an answer quickly. Our median steroid doses come right down. So we're giving much less unnecessary steroid therapy, and we're able to stop that much sooner because with the aid of the ultrasound, we've got more clinical information to help us get to that secure diagnosis. So next slide, please. We had a problem during the COVID outbreak in that the common symptoms of giant cell arteritis are headache, being unwell, being achy and having high inflammatory markers, and of course all these can be features of COVID as well. And we did have some cases which came up with suspected COVID and actually with giant cell arteritis, and some patients who came up with suspected giant cell arteritis who actually turned out to have COVID. So we ended up doing systematic literature review, which we ultimately got published to just compare the frequency of sequence and signs and identify discriminating features. And in giant cell arteritis, there's this thing called jaw claudication, which is an aching in the jaw when you chew, which is pretty specific for giant cell arteritis. So we've been using that a lot as being quite diagnostically informative in these grey cases where we're not quite sure. It's a bit of a non-specific and acute presentation, and it might be one thing or the other. So next slide, please. We also wrote up our experience of how we rejigged our clinical pathway during the peak of the COVID alongside some other international authors, and we recently published that in a journal called Lancet Rheumatology, which is shown here. So next slide, please. So what are we going to do next? One thing that we did a little bit of, but we wish we'd done more of, and we want to do more going forward, is patient involvement. So this pathway is quite an acute pathway, so most patients going into it have never heard of this disease, and then hopefully we get them through so quickly that if they don't have giant cell arteritis, they never care about it ever again. But it is really important to have as much patient involvement as possible in everything we do. So that's something going forward. We want to increase the amount of patient involvement we have in our QI, which is ongoing, to try and improve the speed and also the quality of care that we give. We're going to set up a few audits for to audit particular items about the quality of care of patients who are ultimately diagnosed with giant cell arteritis, according to some recent guidelines which came out early in 2020. And the third item is prioritisation. So some weeks we have quite a lot of patients referred for temporal artery ultrasound, and some patients sometimes we don't. And we want to create a system which is more amenable to being adopted by a routine radiology department, so that patients who are high risk can be prioritised for a very rapid scan, and patients who are low risk might wait a few more days without any clinical detriment. So we're looking back at our figures to see if there are particular key features, and jaw claudication is definitely one of them, which would speed patients to an urgent scan in that kind of situation. And we hope that a prioritisation system like that would also help other hospitals adopt temporal artery ultrasound when perhaps they don't have 7 days a week or 5 days a week ultrasound cover. Even if it's just a couple of days a week with this test, it may very well be possible if there's a prioritisation system that we can use. And Kate Smith, and Borsch and Sarker, who are sonographers, have been working with us on what that might look like, how that might happen, and that's a work in progress. So thank you very much for your attention. It's really great to be able to just report back on how we've been doing. I'd like to again to thank the whole of the team who have been amazing, and I'd be happy to take any questions to myself or Kate about any of this work.
That's fantastic. Thank you very much, Sarah. That's absorbing, really, really good to listen to, and great work there. I think as we normally do, we'll pick up Q&As at the end. So really appreciate the update, because we've one other item today for report out, which is Natasha, our very own Natasha, KPO specialist, and Roger from the Programme Management Office. Great to see you both, and congratulations to both of you, because it's a nice moment this. It's your Lean for Leaders certification, so please accept your virtual certificate and congratulations. And just hand over to you both. Did you want to add anything?
Thank you. Mine would just be a tiny bit of advice and a bit of a plug for the LIM community, in saying Lean for Leaders and Advanced Lean Training, it's a little bit like learning to drive, in that you never truly learn how to drive until you've passed the test. And I've certainly learned much more applying it in my own work since I've graduated than I think I did in the classroom. And it's so good to have that support from the other people going through that at the same time. So I would say definitely join the LIM community as soon as you can. So no pressure, Roger, but we'll be looking out for your name as well.
Fantastic.
Can I just add, thanks, Julian. I'm already a member of that community, Natasha. So, but yeah, I'd just like to add that thanks to all the KPO team for all the support they've given me to get through to the end of the course. So thank you very much for that.
Great. That's great. Well done, both of you. So Q&A, a few minutes for questions. Obviously, you've heard from Sarah and the team and the great work there, and also anything you'd want to ask Natasha or Roger about their experiences, Lean for Leaders certification, and indeed anything at all, really. So Q&A, who'd like to kick off? Chris.
Hi, Julian. Hi, Sarah. I just recognising that there are many challenges brought about by the current pandemic, and just really amazed that you've been able to continue this fantastic improvement work for the benefit of patients. I just wanted to kind of get a feel for the main challenges during this period and how you faced and overcame those to continue the great progress.
Okay, we had a lot of challenges, and you can actually read about them a little bit more in that Lancet Rheumatology article if you want to read about them in more detail. And we tried to kind of separate them out and describe how we overcame each one of them. So we had challenges in terms of the diagnostic confusion with COVID-19. That was an issue because we didn't want to bring patients with active COVID-19 onto the Chapel Allerton site, where there were loads of immunosuppressed patients, and at that time that was supposed to be a cold site. We overcame that by instituting a sort of structured telephone pre-screening, which was done by a doctor, going through COVID symptoms, going through giant cell arteritis symptoms, and really trying to risk grade how likely they are to have either of these diseases, and make a clinical judgment as to whether this patient represented significant infection risk. Did we, at the time in the first peak, it was taking a long time for swabs to come back. longer than we were comfortable to let them wait without steroid therapy if they did have giant cell arteritis. So there was quite a lot of difficult clinical decisions to make at that time as to whether we swabbed and waited for COVID. Did we bring them up and do an ultrasound? What did we do? It's much easier now that there's a faster turnaround time for COVID swabs, but we are still faced with this challenge in the current peak as to the diagnostic confusion, and we have had a few near misses where patients with COVID were rapidly redirected away from this pathway. Because it was originally thought they had giant cell arteritis, and very difficult for GPs to assess these patients over the phone. So remote consultations has been a challenge because previously GPs would see the patients face to face and make a clinical judgment on that basis. But trying to assess patients over the phone who might have giant cell arteritis or might have COVID, very difficult. And so we've recognised that, and we've had a lot more kind of consultant involvement in making those clinical decisions over this time, which I think has been good and something we want to continue. We've also had staff problems, so unexpected or expected leave due to COVID, shielding, self-isolation, you name it. So we've had to, everybody in the pathway, every single person has had to have a nominated backup person who could step in at short notice, because this is not something you could just put on hold for a couple of weeks. The pathway has to continue. So we have been doing that. We've it's been really great. We've had some registrars who have now been earmarked as being sort of dedicated to taking these calls from PCAL, and that's worked really, really well. And then, of course, follow-up, because we put patients on pretty high-dose steroids, which then puts them immediately into the shielding category. So, so follow-up has had to be quite selective as to whether it's sort of telephone follow-up, whether it's face-to-face follow-up, how we make that clinical decision at the end of the day. And sometimes integrating all the clinical information with the diagnostic information has been challenging, and we've been really fortunate. I didn't mention this in the presentation, but we set up a multidisciplinary team meeting once a month with the sonographers, with the pathologists, with the clinicians, and we discuss particularly the tricky diagnostic cases every month, and that's been a great learning experience, and as well as improving patient management as well. And it's meant that we've all kept on learning as a team about how to do this better, how to streamline our pathway, and we've identified several aspects that we can improve on, and we also discuss how we're coping with the various different challenges put in place by coronavirus, depending on the very rapidly evolving situation.
Great.
So there's been quite a lot to contend with.
Brilliant.
But it's been a really positive experience and a good experience, I think, for all of us throughout.
Great stuff. Thank you very much.
Great. Thanks very much, Sarah. Any other questions? Well, that's been perfect timing. Can I just say that's been really good to listen to. Oh, Anthony's raised. Anthony, you got a question? Oh, it's Tony. I always call you Anthony, don't I, Tony?
I answer to both, Julian.
Yes.
Thank you. Yeah, fascinating what Sarah's just been reporting on, and she just raised at the end there the importance of sharing learning. So I was just so impressed by the transformational activity of what Sarah and her team are doing at the local level. But alongside that is this constant realization, clearly in Sarah's own perception, but in that of the team as well, of putting that into a global context. And so my question is really, what challenges did she find, did she discover in finding the time to write up and publish so promptly in the Lancet the fantastic initiatives which are taking place here in Leeds?
Well, okay, so I think one answer to that is finding co-authors that actually co-author.
Yeah.
So I was very lucky to identify some very equally passionate clinicians who were willing to co-author this with me. And one of my co-authors actually is a patient research partner who we've worked with for some years. She's at that time she was the president of the chair, of PMR GCA Scotland, which is a patient organisation. So she's a patient rather than a professional, and she herself has been supporting sort of Scottish patients with giant cell arteritis and polymyalgia rheumatica for many years, and serves on their helpline. So she was very aware of the patient perspective. So really, we kind of tried to put all our thoughts and our experiences together with those co-authors, and in a way, because there was a lot going on, and in some ways COVID, you can feel quite isolated because we're not allowed to have our face-to-face meetings anymore, and sometimes when you're trying to deal with all these different challenges, you know, it's great to do it as a local team, but it's also good to reach out to like-minded people across the world who are also facing challenges. And so I had a co-author from New York, where they were also pretty badly hit in the first peak, worse than we were in Leeds. But then also someone from Queensland, where they didn't really have much COVID, but they faced other challenges in relation to the pandemic. And it was just quite useful just to kind of talk through with other people who as to what their take was on all of this. And I think it helped us make our changes on the ground in Leeds, just having those connections with other teams elsewhere in the world. And it was almost a little bit like therapy in some ways, writing about what we've been doing and how it had been difficult, and also trying to adopt multiple perspectives globally, and also the patient perspective was quite helpful for us, I think, to keep everything in, to keep things in proportion, and to realise that, you know, in Leeds, we have been facing the same challenges as everybody else around the world, and that actually we were quite lucky because we did have the opportunity to improve. And that was because, unlike in New York, where they were totally overwhelmed and everyone got redeployed to acute COVID and no one could redesign the pathway, so they weren't able to do very much. And in Queensland, they didn't really need to redesign their pathway because COVID didn't really have any benefit at all. But we identified, I think, some changes during COVID that have been actually will be useful going forward, such as having a more flexible remote versus in-person follow-up model, really trying to make that diagnosis very quickly, improving the way we communicate with patients and send them communications, you know, potentially electronically rather than just via a letter. So all sorts of things which we've done, which will be helpful going forward. So it made me realise how lucky we are in a way in Leeds that we had such a dedicated team for improvement, and that we were kind of in that sweet spot of, yes, COVID was absolutely dreadful in the first wave, but we weren't quite as overwhelmed as in other places, and we were able to put some things in place that hopefully will make the pathway better going forward, even once the COVID era has gone and passed and COVID's under control. We will be able to learn from what we've done during this outbreak and use that to improve the quality of care going forward for our patients.
Thank you.
Great. Thank you very much. Chris, have you still got your hand up?
Yeah, it's just a question for Natasha and Roger. Recognising that improvement's a continuous journey, I just wonder what success looks like for both of them after a year post their Leeds improvement graduation.
Good question, Chris. I suppose, yeah, for me, it's just the sort of change of practice that the tools and techniques that I've picked up through Lean for Leaders has brought on, and it's enabled my sort of, you know, I think the difficulty is sort of integrating those that good practice into your everyday working day. So once you get over that hurdle, you realise that actually it's hugely beneficial to your working day and actually makes it a lot easier.
Brilliant. And the same question for Natasha as well.
I would echo exactly what Roger has said. My certificate's actually been a long time coming. I've managed to wiggle out of receiving it. So since then, I've gone on to team leading lots of events. I've gone on to teach Lean for Leaders, and I personally think I've learned much more from getting out there and doing the doing than I did in the classroom. So what success looks like for me every day is empowering others to do it and to be authentic and use it in my everyday life and feel the benefits for us in the KPO team as well as out there in the organisation.
Excellent.
Great. I think that's a great note on which to end. So thank you very much, everyone. That's been really good and prompted lots of interesting questions. So thank you to Sarah, Natasha, Roger, and look forward to seeing you all again, same time, same place next week. Thanks very much. End of report out. Thank you.